Good morning. And first of all, Yusuf, thank you very much for your gracious introduction. And on behalf of the American College of Cardiology, I think most of you in the audience realize how important you are to us, both as a country, but also institutionally as fellow cardiologists and cardiovascular surgeons. So it's a great honor for me to be here, along with my colleague, Menno Walsh, who's the president-elect of the college, who's here as well. This morning, I'm going to speak to you about a perplexing problem for us in the United States, and that is the deluge of patients who present with chest pain to our emergency rooms. And in particular in the United States and where I live in Southwest Florida, this is a huge issue because we have a large number of patients presenting with low and intermediate risk chest pain who spend a great deal of time in our emergency rooms and sometimes in our hospitals and preclude our ability to adequately care for other patients. Most of these are actually at low risk, but how to triage those in a safe and effective manner is highly problematic. I have no disclosures. So what I'm going to do fairly rapidly is review some issues regarding guideline-directed care. I'm going to review some data, some of it quite recent, as well as opinion pieces regarding this that may influence us. And then I'll give you an example of how we approach the problem, which isn't necessarily perfect, but it gives you at least one snapshot of the way that we do it at our institution. Much of our guideline is based on this document from 2014, an ACC-AHA joint guideline for management. And I do want to point out the lead author, Dr. Amsterdam, because I'm going to come back and quote him later in this talk. Class 1 indications, as most of you know, are to perform a 12-lead electrocardiogram and sometimes to repeat that if the patient continues to be symptomatic, to measure cardiac troponins serially. It's no longer recommended that CPK or other enzymes be utilized, although sometimes BNP can be useful as well. There's also a suggestion to use risk scoring in patients with acute coronary syndrome, and that risk stratification as a class 2 indication may be helped by such risk stratification methods, and we'll talk about that in a moment. Now, this is a change from the older guidelines that were published several years ago. Class 2A now, level of evidence for all of these are, first of all, utilizing a chest pain unit, as we do, is considered to be a reasonable thing. As well, some sort of a stress test or a CT angiogram are both considered to be reasonable options. Class 2B evidence. Actually, stress testing in the previous iteration of guidelines was a class 1 indication. It's been moved to a class 2, and I'll show you some of the reasons for that. Now, more recently, we published this document principally in collaboration. The lead organization was actually ACR, which is the American College of Radiology. And I will tell you that this particular document, while we are signatories, is not without some controversy. Indeed, the American Society of Echocardiography, American Society of Nuclear Cardiology were not completely bought into this. But I'll draw your attention to the bottom part here, that for low and intermediate likelihood of STEMI or ACS, that it is considered appropriate to do a coronary CTA and rarely appropriate to do resting studies, including resting echo. If the initial studies are normal, it's considered, again, appropriate to consider CTA and may be appropriate for RESPECT-T. For patients with serial studies that are not positive for ACS or STEMI, there's a variety of options. So this tells you a little bit, this is where we get into the gray zone of what should I do. Appropriate, according to this document, includes exercise ECG, stress echo, stress CMR, stress SPECT-T, or CCT. Cardiac cath considered rarely appropriate. So there's a fairly broad spectrum of recommended modalities, which leaves this fairly wide open. So if we go back and look at the data, Dr. Budoff, as early as 2008, did demonstrate that utilization of coronary CTA was a reasonable approach, and it could be useful for ruling out significant coronary disease in patients who presented with chest pain. Several years later, this study, CT-STAT, came out, and interestingly enough, compared with standard of care, suggested that in low-risk patients, utilization of CTA might shorten the length of stay for evaluation of patients with chest pain. And this got quite a bit of press because the time issue is really problematic for us. More recently, Pam Douglas and her PROMISE investigators published this study within the past year and a half. This study design was a randomization of 10,000 patients who either got an anatomic strategy with coronary CTA or a functional strategy with some sort of stress testing. In this particular case, the stress testing modality was left up to the treating physician. And if one looks at the primary endpoint, death, MI, unstable angina, major complications, there really was no difference between either the anatomic or the functional strategy. There was a difference in findings of invasive catheterization without obstructive coronary disease. Not surprisingly, those that underwent an anatomic strategy with CTA had a lower likelihood of a negative coronary angiogram, and the authors pointed out that we might save some extra resources by going this direction. But there was no difference in terms of the clinical outcome in either case. Pam Douglas and her group followed this up with the platform study published in the ESC journal shortly after that, and they added, in this case, a somewhat smaller trial, but one which added a functional element to the anatomic element, that is, utilizing functional flow reserve calculated from the coronary CT angiogram. This was a little bit more complex schema where some patients were initially planned for a non-invasive test on the left, and others were planned for invasive coronary angiography, and then they were subsequently randomized to the planned modality or to an FFR CTA. And essentially what Platform found when they looked at this intermediate risk population is that there was a reduction in the rate of negative coronary angiography, as you might imagine, in the CTA group. There was no difference in the outcomes in terms of MACE. There was cancellation of a significant number of invasive coronary angiograms in the CTA group. But again, no real difference in outcomes long term. Now, just a couple of days ago online was published the Scott Hart trial. Some of you may have seen this online. It came out in JACC. This is out of Edinburgh. This is really a very interesting trial and quite a large trial that looked at outcomes with coronary CTA versus a standard functional study. And although this is a little bit difficult to read, what I can tell you is that in the top curve, it tells you the difference in antiplatelet therapy use following a presentation of patients with chest pain who were looked at with coronary CTA versus the standard. So this is a significant difference, and then below that is the statin difference. So there was a difference in treatment of patients who were evaluated with coronary CTA as compared with functional. Perhaps even more impressive is this, and that is that if one looks at the 3-year outcomes, there's essentially a halving of the outcome with regard to death or non-fatal myocardial infarction. Now, the numbers are relatively small. It's a drop from about 2.5% to roughly half of that in the CTA group. But one can at least hypothesize that the functional or that the structural evaluation led to preventative therapy, which downstream several years later resulted in a lower event rate. To the best of my knowledge, this is the first study that's really shown a difference in outcomes like this with an anatomic structure, an anatomic approach. So it's very interesting, and one has to decide, is it cost effective and needs to be followed up. Now, presented just last week at ACC 16 in Chicago was this study out of the Mayo Clinic group. This is a fascinating approach, and this very complicated slide is a form that is utilized by these investigators to do shared decision making with patients in the emergency room at the time of chest pain. And one of the things I found particularly interesting is they use this pictograph that one sees on the right to visually display to the patient that once they've gone through the standard process of evaluation with electrocardiography and serial troponins, the statistical probability of an event within 45 days is only about 1%. And so for you and I, that makes perfect sense. We can visualize this. But they use this pictograph to show this to patients and say, okay, so far you've ruled out your likelihood of an event is down here in the bottom. You're this little red guy, perhaps 1%. Now, knowing that, here are several options that include functional testing, anatomic testing with CTA, discharge with follow-up with a cardiologist for further discussion, discharge to your primary care physician, or leave it to the emergency room doctor. And what they did, fascinatingly enough, is they took roughly 900 patients, and half of them were treated in the standard fashion with the decision made by the attending physicians, and half were evaluated with this decision tool, this shared decision tool. And as you see, statistically at least, there was really no difference in the outcome at 30 days. So there wasn't any grave danger presented. And you and I would not be surprised by that because, again, the 30-day outcomes with low to intermediate risk, but especially low risk, are only about 1%. Now, the resource use was very interesting as well. So there was a substantial reduction, statistically significant, in admissions in the group of patients that were given their option with this pictograph. There were less stress tests, and there were about the same number of coronary CTAs, although the number was not great. So from a resource standpoint, and at least in the United States, we're having to pay closer attention to this cost equation. There was a substantial reduction in resource without compromise in this relatively small study of safety. So it's an interesting approach. It's a big issue for us in the United States and in ACC to utilize shared decision-making tools, and this one is particularly of interest. Well, some of the things that have come up with regard to the low likelihood of outcomes and some of the limitations with testing led Dr. Amsterdam, recall that he was the lead author in the current ACC-AHA guidelines, to make this statement in 2014 that perhaps it's reasonable to quit routinely doing stress testing on everyone that presents with chest pain, which at least in the United States has been the standard. The standard has been stress testing with an alternate now for CTA. So the other thing to comment upon, and many of you in the audience may have more experience with this than we because in the United States not widely available yet, but the use of high sensitivity troponin has great promise, and I'll call your attention to the back trial in the middle where the negative predictive value for a normal high sensitivity troponin done 1 hour after onset of chest pain is 99.7%, and it's 100% if it's after 3 hours. So this also presents another nuance in the way that one might triage and evaluate these patients and decide to discharge them and whether or not they have further studies. So right now, what do we do with these patients who rule out, if you will, for acute coronary syndrome? Do we send them home and say, it's okay, you have a low event rate, we'll watch you and see what happens? Do we do some sort of functional testing? If so, which one? Or do we consider an anatomic structure, an anatomic evaluation with CTA probably, and with or without functional flow reserve? By the way, I would comment here that many of us who've done this for a while have been a bit concerned about the CTA approach because we've been concerned that if a person presents with chest discomfort, has a CTA that shows a lesion, say a 70% circumflex lesion, that there might be a temptation to intervene on said lesion without really knowing if that is functionally the cause of the patient's presenting complaints. So a potential problem. And I will say that the platform investigators addressed that specific issue by saying, by adding FFR to the CT, at least you're getting some functional information as well. But there is still an issue about utilization of resources in such a case. So quickly, I can tell you that in our situation, we use a guideline-driven protocol. It is physician-directed, but is facilitated by our advanced care providers, and that's an important issue. Our goals are, as stated here, principally to improve patient care, but we're also trying to improve my efficiency. Much like you, it's not uncommon to come to the hospital at 6:30 in the morning and find myself with 6 chest pain consults waiting to be seen, and I have to figure out how I'm going to triage those while also making rounds, going to the cath lab and doing other things. So it's to improve my efficiency and improve facility management. So we use a protocol-driven approach. We have dedicated units. I supervise 4 different hospitals in our system. We have units at all 4. They're staffed with 2 advanced providers and with dedicated staff that are accustomed to doing this. We use a modified appropriate use criteria, and by that I mean that we took the ACC appropriate use criteria for stress testing. We looked at the guidelines. We laid this out in an algorithm and protocol, but then that was modified somewhat to our local use to make certain there was buy-in from the local community. The cardiologist on call for the chest pain unit can modify the protocol at his or her recommendation, and that does happen, as you might imagine, but generally our compliance with protocol is roughly 90%. We track this. Outpatient stress tests by protocol are done within 72 hours if the patient is discharged. We make exception if we think that there's a social or financial reason that we might not have adequate follow-up. We utilize the heart scoring system, a busy slide again, but just to remind you that having some sort of an objective risk stratification tool is felt to be useful. We used to utilize TIMI scoring, but recall that TIMI scoring was actually developed for acute coronary syndrome. The heart score was specifically developed for evaluation of chest pain. That's why we changed over, and it gives us an opportunity to risk stratify into low, intermediate, and high risk. And for our purposes, our chest pain unit goes up to 6 on the heart score, so in the intermediate range. Everybody above that gets admitted to our cardiac care unit. So this is, again, a very busy slide, but essentially what it says is that we quickly risk stratify. We make certain that there is no ischemic change on the electrocardiogram or an elevated troponin, point of care testing to increase rapidity, and that they're in the moderate to low risk. If so, they are sent immediately to our chest pain center, where we do serial electrocardiograms at 0 and 6 hours, troponins at 0, 3, and 6. If those are negative, then we either send the patient home for outpatient follow-up or we proceed to stress testing. And again, this protocol can be broken by the attending cardiologist. Utilizing the appropriate use criteria for nuclear stress testing, we generally reserve nuclear stress testing for moderate to high-risk patients or those with known coronary disease or non-interpretable EKG. Now, what that means in English is that we generally do regular stress tests because in our patient population, most of the people who present to our chest pain center are low to intermediate risk. They don't have coronary disease. Those go elsewhere, and they most frequently have an interpretable EKG. So I can tell you that when we started our program, the pattern of care and the standard of care in our community was that people presenting with chest pain got a nuclear stress test about 95% of the time, which is a huge utilization of resources, both in terms of money, time, and radiation exposure, and that doesn't happen very often anymore. They still get them, but only when appropriate, and as I said, our compliance with protocol is quite high. In our situation, currently, we reserve coronary CTA for patients who come in a second time. So if you've been in the emergency room and ruled out once before within 12 months, we do not go through the standard protocol. Those people go directly to our 64-slice scanner and get a CTA immediately and then move on. We do not do CTAs routinely, although we reserve that for select patients. So our key elements are low to intermediate risk, negative troponins at up to 6 hours. Sometimes we abbreviate the protocol. No dynamic EKG changes. Functional testing within 72 hours, except for the situation with CTA that I mentioned. And we use our testing protocol algorithm unless overridden. And importantly, the process is facilitated by advanced care providers. When we started this, believe it or not, our average length of stay was about 32 hours. we dropped that to 17 hours. And I will tell you, in our case, that 17 is even exaggerated because that includes some weekend cases where not all testing is available in not all institutions. So we essentially cut the time in half without compromising the quality of the workup. Now, interestingly enough, the patients in our institutions who were assigned to usual care, not to our chest pain center, also experienced a significant, though not quite as much, reduction in length of stay. We believe that this is a bleed over from the protocols that we had in place that now have been adopted by our other physicians not utilizing the chest pain center. In terms of finances, we've saved about 1,500 beds last year. We've had readmission rate from 0.2 to 2% with no death rate. And essentially what we found is improvement in patient satisfaction. You have a few issues that I've mentioned here. And essentially, we believe that following science and guideline, but with local buy-in, dedicated units, advanced care providers, physician champion, and being able to show a return on investment is important, and you have to follow the science. We believe that it will change. So thank you very much for your attention.